This topic is on renal stones and ureteric colic, and it follows the NICE guidelines of 2020. Urolithiasis refers to the formation of stones anywhere in the urinary tract, such as kidneys, ureters, and bladder. Renal and ureteric colic refers to the severe, acute, usually loin to groin pain due to the movements of the stones or from the obstruction of the urine flow through the ureter. Urinary stones usually form when urine becomes excessively supersaturated with a mineral, leading to crystal formation. There are multiple types of urinary stones. The most common type is calcium stones. 80% are calcium oxalate, and 20% of these are calcium phosphate stones. Calcium oxalate stones are associated with low urine volume and high levels of calcium, oxalate, and citrate levels in the urine. Calcium phosphate stones are associated with low urine volume, high calcium in the urine, high urinary pH, and conditions such as primary hyperparathyroidism and renal tubular acidosis. Uric stones cause about 10 to 20% of urinary stones and is associated with low urinary pH, less than 5.5. Struvite stones, which is a mixture of magnesium, ammonium, and phosphate compound, causes 1% of urinary stones, which usually results from a bacterial urinary tract infection such as Proteus, leading to raised urinary pH. Other urinary stones may be caused by cystine stones and drug-induced, such as furosemide, allopurinol, and vitamin D. Most renal stones do not cause symptoms. Pain may arise when the movements of the stones cause smooth muscle spasms, hyperperistalsis due to obstruction, edema, and mucosal irritation. Obstructions further induces diuresis, which further increases pressure in the kidneys. The three common sites of urinary stones are vesico-ureteric junction, mid-ureters, where the ureters crosses the iliac vessels, and the pelvi-ureteric junction. Risk factors can be categorized into non-modifiable and modifiable risk factors. Non-modifiable risk factors include older age, male gender, white ethnicity, and anatomical abnormalities. Modifiable risk factors include excessive dietary intake of oxalate, urate, sodium, and animal protein, dehydration, and drugs. Complications of this include AKI, which will lead to an irreversible kidney damage if left untreated, obstructive pyelonephritis, sepsis, and hydronephrosis. Renal and ureteric stones are also associated with increased risks of renal cell carcinoma, CKD, and coronary heart disease. To assess for renal stones, it's important to take a good history and examination. Loin to groin, 10 out of 10 pain is classical. Urine dipstick or microscopy and culture would show hematuria. Perform routine bloods, especially renal profile and inflammatory markers, and consider performing metabolic investigations such as serum calcium and stone analysis if patient manages to pass any stones. It's important to obtain urgent imaging within 24 hours. For most adults, offer low-dose non-contrast CT of the KUB, kidney, ureter, and bladder. If the patient is a pregnant woman, offer ultrasound instead of CT. For children and young people, offer ultrasound as first line. Admit immediately if patient has one of the following symptoms: systemic symptoms like fevers and sweats, pre-existing kidney diseases, reduced oral intake, nausea, vomiting, or doubtful diagnosis. For all other patients with suspected renal or ureteric colic, obtain urgent imaging and give NSAIDs such as diclofenac for pain if not contraindicated. Do not offer antispasmodics to people with suspected renal or ureteric colic. Management of urinary stones would depend on two things: presence of complete obstruction and the size of stones. Patients with complete urinary obstruction would need to urgently relieve the blockage via drainage procedures like percutaneous nephrostomy. Management is also influenced by the size of stones. If the size of a stone is less than 5 mm and patient is asymptomatic, watchful waiting is recommended to allow natural passing of the stone. If the stone is less than 1 cm, an alpha blocker such as doxycycline is recommended. If the stone is more than 1 cm, or if patient is experiencing ongoing, untolerated pain, surgical treatments can be offered. The type of treatment is based on the size of the stone, age, contraindications such as pregnancy, or any anatomical considerations. These would include shockwave lithotripsy, percutaneous nephrolithotomy, ureteroscopy, and open surgery. To prevent further recurrence of urinary stones, lifestyle management can be recommended. Encourage patients to increase fluid intake, avoid carbonated drinks, reduce salt intake, but do not restrict calcium intake, as this may paradoxically increase the risk of further stone formation. Consider potassium citrate for recurrent stones in adults with predominantly calcium oxalate stones. Thiazide treatments can also be considered as well if these criteria are met. These should be under the discretion of secondary care. In summary, it's important to know when to suspect renal and ureteric stones, understand the risk factors and the different types of urinary stones, the complications, the different treatments according to sizes and presence of obstructive symptoms, and the different lifestyle managements to prevent further stone recurrence. Thank you for watching this video. Subscribe for more.